A stroke is a neurological deficit caused by a disruption in the blood supply to a localized area of the brain, resulting in cellular injury and, in some cases, cell death. Stroke is classified into two major types. 1. Brain ischemia due to thrombosis, embolism, or systemic hypoperfusion. 2. Brain hemorrhage due to intracerebral hemorrhage, ICH, or subarachnoid hemorrhage, SAH. Approximately 80% of strokes are due to ischemic cerebral infarction and 20% to brain hemorrhage. The subject matter of this video will revolve around ischemic stroke, which will be discussed in detail. Ischemic strokes are characterized by the abrupt, or at least very acute onset of focal neurologic symptoms and signs that leave persistent neurologic deficits. There are three main subtypes of brain ischemia: thrombosis, embolism, systemic hypoperfusion. Blood disorders are an uncommon primary cause of stroke. However, increased blood coagulability can result in thrombus formation and subsequent cerebral embolism. Thrombotic strokes are those in which the pathologic process giving rise to thrombus formation in an artery produces a stroke either by reduced blood flow distally, low flow, or by an embolic fragment that breaks off and travels to a more distant vessel, artery-to-artery embolism. Thrombotic strokes can be divided into either large or small vessel disease. These two subtypes of thrombosis are worth distinguishing since the causes, outcomes, and treatments are different. Large vessels include both the extracranial and intracranial arterial system. Pathologies affecting large extracranial and intracranial vessels can differ, but atherosclerosis is by far the most common cause of in situ local disease within both extracranial and intracranial vessels. Vasoconstriction, for example with migraine, is probably the next most common, followed in frequency by arterial dissection and traumatic occlusion. Small vessel disease affects the intracerebral arterial system, specifically penetrating arteries. These arteries thrombose most commonly due to lipohyalinosis, a lipid hyaline buildup distally secondary to hypertension. Thrombosis in penetrating arteries can also be caused by the formation of atheroma. A stroke due to obstruction of these vessels is referred to as a lacunar stroke. Embolic strokes are divided into four categories: those with a known source that is cardiac, those with a possible cardiac or aortic source based upon transthoracic and/or transesophageal echocardiographic findings, those with an arterial source, artery-to-artery embolism, those with a truly unknown source in which tests for embolic sources are negative. Unlike thrombosis, multiple sites within different vascular territories may be affected when the source is the heart, for example, left atrial appendage or left ventricular thrombus, or aorta. The symptoms depend upon the region of brain rendered ischemic. The embolus suddenly blocks the recipient site so that the onset of symptoms is abrupt and usually maximal at the start. Reduced blood flow is more global in patients with systemic hypoperfusion and does not affect isolated regions. The reduced perfusion can be due to cardiac pump failure caused by cardiac arrest or arrhythmia, or to reduced cardiac output related to acute myocardial ischemia, pulmonary embolism, pericardial effusion, or bleeding. Hypoxemia may further reduce the amount of oxygen carried to the brain. The most severe ischemia may occur in border zone, watershed regions between the major cerebral supply arteries, since these areas are most vulnerable to systemic hypoperfusion. Blood and coagulation disorders are an uncommon primary cause of stroke and TIA, but they should be considered in patients younger than age 45, patients with a history of clotting dysfunction, and in patients with a history of cryptogenic stroke. The blood disorders associated with arterial cerebral infarction include the following disorders: As brain ischemia occurs by any of the mentioned mechanisms, it initiates a cascade of events that eventually lead to cell death, including depletion of adenosine triphosphate, ATP, changes in ionic concentrations of sodium, potassium, and calcium, increased lactate, acidosis, accumulation of oxygen-free radicals, intracellular accumulation of water, and activation of proteolytic processes. Cell death following cerebral ischemia or stroke can occur by either necrosis or by apoptosis. Low levels of ATP within the core infarct are insufficient to support apoptosis, and cell death occurs by necrosis. In the ischemic penumbra, ATP levels are sufficiently high that cell death by apoptosis can occur. As the duration of ischemia increases, however, ATP levels are eventually depleted and the proportion of cells that undergo necrosis is increased. Globally, ischemia accounts for 62%, intracerebral hemorrhage 28%, and subarachnoid hemorrhage 10% of all incident strokes, reflecting a higher incidence of hemorrhagic stroke in low- and middle-income countries. In the United States, the proportion of all strokes due to ischemia, intracerebral hemorrhage, and subarachnoid hemorrhage is 87, 10, and 3%, respectively. The lifetime risk of stroke for adult men and women, 25 years of age and older, is approximately 25%. This risk is higher for females compared with males. Regarding location, the highest risk of stroke is found in East Asia, Central Europe, and Eastern Europe. The major modifiable risk factors for stroke are the following: hypertension, dyslipidemia, diabetes, smoking, and physical inactivity. Important but unmodifiable risk factors for stroke include the following: older age, particularly age more than 80 years, race and ethnicity, with risk higher for Black than for white patients, sex, with risk higher at most ages for men compared with women, except for ages 35 to 44 years and more than 85 years, where women have a similar or higher risk than men, family history and genetic disorders, with a higher risk for monozygotic twins and those with genetic disorders.